Hello everyone, welcome to this seventh webinar about big data. My name is Eva Watt, I'm the Training and Capacity Lead for Annual Support. And I would like to inform you that this session is being recorded. The PowerPoint presentation and the recordings will become available after the webinar on our website. We have disabled cameras and microphones for the participants, so if you would like to share a question or a comment, please use the chat box. That are the more practical things. We have a slightly different webinar today than you might be used to. So we have three different guest speakers today. First, Saeed Samet will share with you what big data is. Then Kris Aubrey will share an example from a primary care setting. And then Elizabeth Dix will share how you can access data in Newfoundland and Labrador and what kind of ethical considerations you should take into account. So that's it. Just a quick check. Can everybody hear us? Can you please chat or vote to let us know? Yeah? Okay. Then I'm going to hand it over to you, Saeed. So I will put my talk and video off, and I hope you enjoyed this webinar.
Thanks, Eva. Hello, everyone. My name is Saeed Samet, and I'm currently working at the eHealth Research Unit at the Faculty of Medicine, as well as cross-appointed at the Department of Computer Science. In this short presentation, I will talk about some general aspects and an overview of big data. As an outline, the talk includes a definition of big data, its main attributes and properties, some current facts on big data, the main differences between small and big data, and finally, big data analytics, their types, and some examples. As it comes from its name, big data is a term that describes the large volume of data that could be structured or unstructured, which keep all the information of a given business on a day-to-day basis. For instance, imagine all data generated each day in a hospital, no matter they are clinical, financial, administration, research data, or other types of information. However, the important aspect of big data is how to analyze these data and their usage by different data users. And therefore, the main insight of big data is data analysis, which leads people to make better decisions, strategic and suitable actions. Big data has some attributes known as 3V or sometimes 5V attributes. The first V attribute is volume, which means size of big data is ever increasing. And the second one is velocity. That means the fast speed of data generation. And the third one is variety, indicating that big data has many different types. For instance, numbers, strings, media files like sounds, pictures and clips, text files, etc. There are two more B attributes that we can consider. The first one is veracity, that shows the trustworthiness of the data and how much we can rely on the generated and the stored data. And the other one is value, that indicates the potential to turn data to valuable information and knowledge. Considering these attributes, we can conclude that, for instance, if we have a fixed large amount of data without any increase on the size, or for instance, with only a single type of data, we can't call it a real instance of big data. Also, some people consider two other V attributes. First one is visualization. That means using charts and graphs and other graphic tools to visualize big data. and the other one is variability, that means constant change of the meaning of data. Other than attributes, big data has some properties as well that basically derived and resulted from the attributes that we saw in the previous slide. They are usually heterogeneous, means they are statistically dissimilar. They are often very complex and hard to analyze. Big data are usually distributed because of various reasons, such as coming from many different sources and having huge volume, and also some type of security and privacy aspect that should not be in one place. And therefore, they are controlled and managed by more than one center. They often have autonomous sources and auto-generated, such as signals generated by wearable devices or autonomous vehicles. And at the end of the day, important thing is that we should see big data as a whole. Otherwise, we will be misguided like the blind man and an elephant in a dark room. It would be good to know some facts about the progress of big data and its usage. In 2012, it has been reported that the amount of global data was about 2.8 zettabytes. And it has been estimated that in 2020, it would be about 5 times larger than the amount of data in 2012. And at least 33% of generated data can be useful. However, only 0.5% of big data is really analyzed and used nowadays, which is very low comparing with the money and time invested in this area. If we want to compare big data with a natural phenomenon, we can say that big data is very similar to icebergs that we have experienced in this province. By the fact that, first of all, it is very big, like icebergs, and but more importantly, the unseen portion of big data, which is useful knowledge and information, is much larger than its visible part. An important thing is to realize the differences between small and big data are not only limited to their size. We can see other important differences as well. For instance, in here I named about 10 differences between small and big data. The first one is that the small data have usually specific goals and purposes that are not the case in big data. And the small data often resides in a single file or physical location. They are frequently structured, while it is not the case for big data having both structured and unstructured data. And small data are usually prepared and maintained by data users for their own use, and this is not the case for big data that are generated by various parties and systems that are not the main users of that information later on. And the small data often have a specific longevity and will be archived and or deleted thereafter. Also in big data, many different types of data are delivered in many different electronic formats, and therefore we are dealing with various units of measurements. And most of the times we can almost easily reproduce a small data, which is not possible or a simple job in big data. Also, fixing costs in a small data are limited if something goes wrong. And usually small data includes additional data that describes the content of the small data. And finally, small data are easy to analyze, even with a single computer. That is not the case in the event of big data. As I already mentioned at the beginning of the presentation, the main purpose of having big data is to what we can get from these types of data. We call this big data analytics, or BDA in short. And as a definition, we can say BDA is a systematic and extensive use of data by the help of statistical and quantitative methods and analysis and predictive models and management tools to make good decisions and take proper actions. And when we are dealing with big data in health and healthcare systems and the related areas, we are talking about health data analysis by obtaining, combining, and managing and analyzing of these data from various sources to, at the end of the day, improve the people's quality of life and healthcare. Now let's talk a little bit about various steps or types of BDA. We can say that there are four major steps for a comprehensive big data analytics. The very first step is descriptive analysis, in which questions like what has happened should be answered to describe the current issues and situation in a specific field. For instance, we ask how many uninsured patients do we have with type 2 diabetes. And now let's explain this analysis using a local example in Newfoundland and Labrador that has been extracted from the annual report provided by the Canadian Diabetes Association, or CDA in short. And then we continue other steps of BDA in the next slide by working and continuing this example. As you know, in this province we have the highest rate of diabetes among all Canadian provinces. And this rate in 2016 was about 12.4%, or around 63,000 individuals of the population. And another descriptive fact is that at the end of 2016, about 35% of the individuals in NL are either living with prediabetes, diabetes, or undiagnosed diabetes. And also about 67% of adults and 47% of youths are overweight or obese. So by this example, we just describe the situation to go to the next step, which is diagnostic analysis. In this step, we want to answer questions like, why has it happened? Those that we explained in the previous slide, by examining descriptive data and their relations and associations. For instance, why does the US have the highest prevalence of diabetes among all developed countries in the world? Again, local examples related to the previous one are to diagnose the reasons of high prevalence of diabetes in this province. We can see that NL has the oldest population in Canada, and its average family income is lower than that in the country. And also NL has the highest prevalence of overweight and obesity and prediabetes that can be somehow help us to diagnose the reason of the high prevalence of diabetes in the province. The third step is predictive analysis, in which using different modeling techniques and simulations and other tools, we answer the questions like what may or what will happen. For instance, can we predict who will be readmitted for heart failure in the next 30 days in a specific hospital? Again, for the previous example, we have some predictions provided by CDA. For instance, financial impact of diabetes in NL will increase from about $254 million to over $322 million per year by 2020, of course, if no proper actions are taken. And also, it is estimated that the number of people diagnosed with diabetes will increase from 60,000 or 12.4% to more than 73,000, which is about 14.4% of population in 2020. And finally, we have prescriptive analysis, which is a very important step nowadays in BDA or big data analytics, in which using optimizations, policies, and actions on clinical, financial, and other outcomes, we should be able to answer questions like how to prevent bad things from happening and how to cover up good ones. For instance, from those patients identified as high risk of readmission for heart failure, is it more cost effective to case manage in the hospital or at home? And in the continuation of the previous local example that we saw in the previous slides, there are some action plans recommended by the Canadian Diabetes Association to prevent and manage diabetes in the province of Newfoundland and Labrador. For instance, creating diabetes registry to track related statistics, and also providing better access to medication, devices, and supplies, and also, of course, providing some public awareness campaigns about how to prevent diabetes in the province. I now wrap up my talk, and before switching to Kris, please let me know if you have any questions. Thank you.
Hi everyone. So my name is Kris Aubrey-Bassler. At least it's showing up on my screen as being that my name is Eva Lidui, but I'm in Eva's office, so that's why you're seeing that. Kris Aubrey-Bassler is my name, as I said. Some of my credentials are up there. I'm director of the Primary Healthcare Research Unit at the university, and also science lead on PRIME, which is the Primary Healthcare Research and Integration to Improve Health Systems Efficiency Network. It's funded from the same envelope of funding as the support unit that Eva works with, so that's part of the reason I mentioned that here. You've just heard from Saeed, who's really a big data expert, among other things. He does privacy research, many other things, but the big data expert. I'm a clinician, a family doctor, as you can see there. My interest is really coming at this from using big data to do some of the research projects that I do. And so, this presentation, or this section of the presentation, will give you some examples of some of the research I do. I don't have a huge amount of time because there's a lot of material to cover in this time, and there's 3 of us presenting. But I'd be happy to talk some more at a later time with any of you if you want to email me. So I kind of include this as a default on any of my presentations. It's standard practice at medical meetings to declare any financial conflicts of interest, and I have none. I'm not paid to, well, I'm paid to do this work, but there's no paid from the university, not from any drug companies or anything like that to present the message that I have. So first, this is some definitions that might help you to with some of the things that I'll talk about. When we talk about big data, it's data, as Saeed told you, it's data that's not really collected for research purposes. It's collected as part of, for example, patients staying in hospital, and that's a big part of what I do, is access data for patients staying in hospital or emergency departments. It's collected just because of the clinical work, the healthcare work that's going on. The hospitals and the emergency departments collect that data for their internal purposes. But we researchers can also access that as well. And so what we do with that type of data is called observational research. It's not a specific research project, but we're doing analyses of data that's collected as part of routine everyday life. The opposite of that is experimental, and I hope you can see my arrow. I'm using the mouse to circle the experimental. Okay, I told you can't. So the top bubble at the top there is experimental projects, which is really what we think of as being the usual scientific experiment. I might want to do a study of a drug, and I will give some patients a drug and some patients a placebo and follow their outcomes. I collect all the data that's relevant to answer that question, specifically for the purposes of answering that question, and so that's an experimental project. The quasi-experimental, which is also a lot of what I do, is in the bottom left-hand corner. That's where some people call it a natural experiment. So we might compare provinces, just to use one of the examples that Saeed used. You heard that Newfoundland has the oldest population in the country, whereas Alberta has a relatively young population. So that's, in some ways, is a natural experiment. We could compare things between the provinces to see how age affects certain outcomes. Now, that's just an example. It's not a great example. It's not what we would usually use, but it's just an example that came to mind. In the interest of time, I'll keep going without spending too much on that. But the other thing I wanted to mention, though, from that last slide is that there's lots of overlap. There's some gray areas between those types of experiments, and so some don't fit one or the other very well. So why observational methods? I'm perhaps a little biased because this is a lot of what I do. I don't do much experimental work, but the problems with experiments, I think I actually have it on the next slide a little bit better. Yeah, so the problems with experiments, or what medical researchers call randomized controlled trials, that's the typical experiment that I talk about, where the patients are randomized into an experimental group, so the drug example that I mentioned, versus a control group or a placebo pill. It's very well controlled circumstances in those types of experiments. But because of being controlled, because of being scrutinized by the researchers and lots of money that goes into these things, they typically take place in large academic centers, highly specialized clinics, for example, and so that's not what the vast majority of people experience in their routine care accessing the healthcare system. And so the results that come out of randomized trials may not be applicable to the 90–95% of the population that don't get their care, obtain their care in those types of environments. So that's where observational studies, they can be done on that other 90–95%. They can be huge, and they may actually be more representative of what happens as part of everyday care, the non-highly specialized clinic care. So I alluded to some of these already. The problems with randomized controlled trials are they're really expensive to run. Drug companies are usually the ones that have the money that can fund it, and so with some exceptions, there are also government sources. Canadian Institutes for Health Research, for example, is the big one here, and then the larger charitable funders like Heart and Stroke Foundation and the Cancer Societies, Canadian Cancer Society, and other things like that. They'll fund big studies as well, but often it's drug company funding, and it's relatively limited and relatively focused on those items. There's no, for example, for my area of expertise in primary care, there's no foundation for primary care. So there's no foundation that will fund really complex interventions. For example, a multidisciplinary team in primary care to improve outcomes on high blood pressure, diabetes. Now, there is a diabetes foundation actually, but complex interventions to deal with really complex patients with 5 or 10 different diseases. There's no foundation that specifically focuses on that. So that's one of the problems with randomized trials as well. And in some cases, there's types of clinical questions that aren't answerable by a randomized trial. So I have the picture in the bottom right-hand corner there showing rural and urban. If we want to compare outcomes between rural and urban areas, or compare interventions in rural and urban areas, we can't do a randomized trial like that, which I hope you can appreciate. So moving right into what I do then. This is a study that we call the Effective Family Physician Retention on ACS, Ambulatory Care Sensitive Hospitalization in Newfoundland and Labrador, 2005 to 2009. So ambulatory care sensitive hospitalizations are those hospitalizations that are potentially preventable by access to a family doctor. So for pneumonia, for example, if you go to see a family doctor early in the course of your pneumonia and you get an antibiotic, it might prevent it from getting worse and requiring hospitalization if it were allowed to progress. Same thing if you have a urine infection. Same thing if you have a stroke. If you went to your family doctor 1 or 2 or 5 years prior and had high blood pressure treated, then you might have prevented that stroke. So all of those conditions are ambulatory care sensitive. It's not to say that they're all preventable. Some of them require hospitalization, but some of them are. So without going into too many details of what we did, we took everybody in the province. So after we excluded a few people that had moved during the year, there were 470,000 people or so. We divided them up in the communities across the province by stickiness. So by the number of family doctors, the proportion of family doctors that were practicing in 2005 who remained in 2009. So that's the retention of family doctors in that community. We divided all the people living in the communities, in those communities, up into thirds. So there was 1/3 with relatively low retention, 1/3 with medium retention, and 1/3 with high retention of their family doctors. And this, the continuity of care, the family doctors that stay in those communities, they may have an effect on the health outcomes of their communities. That was our hypothesis, at least, and we wanted to see what happened. So here are some of our results. The retention, the family physician retention, varied across those communities from 14%, so quite high. That means that 86% of the doctors left those communities over that 4 or 5 year period, right up to 73%, where obviously 27% of the doctors left in those highest retention communities. Interestingly, now it's not what we were set out to find, but part of the analysis that we did during the study showed that the more family doctors within each community actually increased the rate of hospitalization. And it's somewhat interesting. It's been found in other studies. I don't have a long time to go into why that is, but it may be that the communities with more doctors just have sicker populations that require more hospitalization. But on to the real results that we were looking to find is that, this takes a little bit of explanation here, the highest retention communities, so this is the communities that had around 70% or so of their family doctors that were practicing in 2005 were still there in 2009. You can see that their ambulatory care sensitive hospitalization was around 60, just over 60, 62 or 3 per 1,000 people over that 4 year period, 62. In the next tertile up, so the middle range of family physician retention, somewhere around 50 or so % retention, they had around 90 hospitalizations, so half again the number of hospitalization, and it was a tiny bit higher than that for the lowest retention, so the highest turnover in family doctors. So it appears as though from this analysis that keeping your doctors in the community is a good thing. And when we spoke to government about this, then they were quite interested, and they're making changes to try to improve the retention of the doctors in the communities. Things like getting more Newfoundland students into medical school at Memorial, and doing other things to try to keep doctors practicing in Newfoundland. Not only is it may be health outcomes, but there may also be some savings in cost. If you keep patients out of hospital, not only are they healthier, but hospitalization costs a lot of money. And so we estimate, now it's a very rough estimate, but if we were to prevent all those hospitalizations, the province could save up to $43 million per year. So substantial money. I'm going to go quickly over another study. I also have an interest in rural and, sorry, this is not a rural analysis. This is outcomes of deliveries obstetrical deliveries, pregnancy, when they're delivered by family doctors versus obstetricians. So family doctors, I think you probably know, they're generalist physicians. Many of them do obstetrics, deliver babies in rural areas in particular, and also some in the urban areas. But obstetricians are specialized. They have more training than family doctors. They do a lot of deliveries. And so there's some thinking that maybe outcomes by obstetricians are might be a little bit better. And they certainly are better when the mothers are high risk. So when they have complicated medical conditions that family doctors aren't trained to deal with, the obstetricians are trained. We were interested in those other outcomes, in the low-risk mothers, the healthy mothers that are delivering, and what the outcomes might be for family doctors versus obstetricians. So we looked, in this case, we looked at all deliveries across the country over a 3-year period. There were over 800,000 deliveries in our database. So, I mean, obviously, it's not it's impossible to do a randomized trial on 800,000, including 800,000 people. And we linked the hospitalization records for those deliveries to census data and to road network data as well, because we were interested in the effect of traveling on outcomes as well. That was kind of another part of the study that I won't tell you about. And used a technique called small area analysis, which I don't really have time to go into, but it basically compares small regions across the country for health outcomes and for other things. Usually health, it's most commonly used in health outcomes. And this is what we found. We used a new, not new actually, but new to the health system, new to healthcare, new to medical research, analytical technique called instrumental variable analysis. And it's been used by economists for many, many years, but it's a technique that really needs high-powered computing processing, and is perfect for this type of analysis. We found that there's various groups here, which I don't really have time to dive to explain to you. But the bottom line is that we found family doctors do have, for those low-risk patients, and that's a key caveat, for those low-risk patients do have equivalent outcomes to those from obstetricians there. I've included a blank column there for a randomized controlled trial, just to emphasize that it's impossible to do a randomized trial comparing family physicians to obstetricians. People have tried that before, but patients just weren't willing to enroll in those types of studies. So this is the newborn's outcomes, the death of the newborn, and maternal outcomes were similar as well. There was no difference between the, sorry, the slide got changed around a little bit with when it was transferred over to software, but there's no difference between the family physicians and the obstetricians in this outcome either. So that's all I had to talk about. I do have, we'll take maybe a minute or so for questions now, and then we can, I'll hand it over to Betty Dix, who's going to tell you about a little bit to the different slant of data, big data. Incidentally, these methods, just to kind of put a perspective on the analysis of these data, it takes about 18 to 20 hours on a computer for all the stats to run to process all these data. 18 to 20 hours on a computer that's probably 8 to 10 times faster than your usual desktop computer. Yeah, so I can pass along the full studies for those. I've published this one on family physicians. We've just submitted the last one. I've just submitted the last one for publication, so it's not published yet, but I'll circulate that once, hopefully when it's published. Great, I'll hand it over to Betty, and I can, if you want to get a hold of me, K Aubrey, A-U-B-R-E-Y @mun.ca. I'm happy to take questions that way as well.
Okay, thanks, Chris.
Hi, everybody. So, as Chris mentioned, I'm Betty Dix. I'm actually the director for the Center for Health Informatics and Analytics. And we own the high throughput computing system that can run a 4 million variable data set in 3 seconds. So we're running a lot of stats these days. I'm going to put a little bit of a different spin on data and how do you get it, because I deal with people coming to us with even some really simple questions. They don't really want big data. It's tangly data because it might need to link 3 or 4 different data sets with 3 or 4 different groups. So how do you get it, and what is your responsibility once you get it? So I think from an ethics and moral perspective, we have to always be cognizant of that. So for my talk, I'm just going to sort of basically talk about the types of data, both research and clinical, and we're going to discuss some privacy, confidentiality, and the security of personal, health, and other data related to collecting this for research purposes. So I think some people actually interchange words that they think mean the same thing, but in our purpose of collecting data, it doesn't. So if somebody says to you that they're going to collect identifiable data, so that's information that you could expect if you're going to participate in a research study, that they're going to want to know all the details about you. They're going to want to know where you live, what's your address, maybe how much you make, what's your educational level. So that's all identifiable data, so that somebody could actually look it up and say, oh, okay, that's Betty Dix. Then there's the directly identifying information. So when you go into a hospital and they ask you all of your information, who's your family doctor, who's your next of kin, what's your MCP number, this is also directly identifying information, because not only are you just a person participating in a research study that lives on such and such a street, you now have a personal identifying marker that can trace you through the different procedures in a hospital setting. Then there's also the indirectly identifying information. And this is the information that you can reasonably be expected to identify an individual through a combination of indirect identifiers. And I've worked in genetics for a very long time, and I'm always trying to be aware that if we're doing something on an orphan disease, that there's not a lot of people about it, and I'm writing a paper up. We might have 3 cases in the province, and I talk about the fact that it's a small city or small town outside the city, about 50 kilometers out. There's only 3 people. They have red hair, and they all have X, Y, and Z as their appearance. You can technically then read that paper and think, I know who these people are. So that's what we always try to bear in mind. What do you need? How much information do you need to actually conduct your study? And what is it that you don't need, so that you don't have to ask for it? So there's also coded information. Those are direct identifiers are removed from the information, and we would give you a unique code. So we would get information about patients who go to the lab. But I don't care who the patients are, but I do need to know how many times certain patients went for a certain test. So they would take their MCP number off and they would give us a unique code. The people in the lab would know who it is, but I don't know who it is, because I don't need to know. I need to know how many tests were being done. So it's depending on the access to the code. It may be possible to re-identify specific participants later on. Sometimes if I went back to the lab and said, I think that there's a mistake here, they would be the owners of the data. They could actually do the linking. So the coded information does have the potential to be linked back to that person if it's needed. Anonymized information, an awful lot of researchers, and I do spend an awful lot of time because I work with ethics on this, that they'll say in the consent form to patients, your information will be anonymized. Well, anonymized means that even with a relatively detailed amount of work, I cannot link that data back to you. So sometimes people mean that it's going to be coded or it's de-identified, but not anonymized. So the information is irrevocably stripped of direct identifiers. A code is not kept to allow future linkage, and the risk of identification of individuals from remaining indirect identifiers is low or very low. So no matter what I do, I cannot go back and find those patients. They have been stripped of all identifiers. Anonymous information is the information never had identifiers to begin with. Like anonymous surveys. You might get an email, physicians get them all the time, and they're talking about, do you see patients doing this? And it's all done on SurveyMonkey. So we're not asking you your gender, we're not asking you anything else about it, just answer these questions. So that's anonymous information, and the risk of identification of these individuals is low or very low. De-identified data is for the most part what we work with, and the data is de-identified to a level that if it's linked to other data, there's still a reasonable expectation of no re-identification. So when I request data, I usually, unless I need to know specifics, I will always ask for the year of birth, not the date of birth. I'll ask for the first 3 letters of the postal code so that I know the region. I don't necessarily need to know what your street address is, but I would like to know, for argument's sake, what region of the province are sending more patients in for a particular test than another one. So I just need to know the region. And again, I won't ask for your birth date, but your year, of course, will be sufficient so that when I'm doing up my frequencies for my demographic information, I can give some medians and means and that sort of thing. So you can't always de-identify data. There are tests and different surveys and that sort of thing. If we're going to go back to you and give you back some information, if we're trying to put an intervention in place that's going to help you personally, then we can't always de-identify because we have to know to be able to go back to you. So you have to always be aware of what is it that you need, what is going to be the outcome of it, and what is your responsibility after the study. Types of information that we deal with that we get data from all the time. Number one, like the health records, the facts of an individual's health history. And it's exactly what Saeed was talking about. How many patients are diabetics? How many patients are coming to the vascular lab for testing? How many patients are going to the fertility clinics? So those health records are that information that we get. The health record is the physical property of that facility, and the information in it is the property of the client. So we have to get permission from the institution to be able to access it. We have to be able to have and be cognizant that once we get it, it is not our property, it's not Eastern Health's property or the facility that you're getting it from. It is actually the property of the client, and that's under legislation. The organizational information, it's like files, letters, emails. So all of the emails that I send out, a letter that I would send to somebody, that will be organizational information, and that too could be classified as a type of data or types of information that somebody could want. Provincial legislation, we are always aware that we have to follow provincial legislation, and there is the Regional Health Authority Act. There's the Access to Information and Protection of Privacy Act. There's the Personal Health Information Act. And all of these are frameworks for the collection, use, and disclosure of personal information. And depending on what avenue of research that you're doing or the time or type of data that you want, you will fall under one of these provincial legislations. And for the most part here at MUN, we follow FHIA, which is the Personal Health Information Act. And that limits and restricts and allows the type of information that we can request and that we can have access to. So, Access to Information and Protection of Privacy Act, this is the act that promotes the transparency and accountability. Why do you want it? You have to be very clear, your objectives have to be stated perfectly well so that someone can say that you're just not out there looking for something to do, that there's actually an outcome associated with this. This was a new bill that was passed on June the 15th in 2015. There is actually a website that we follow that if we have any questions about what we're allowed to ask for or what can we get, the Information Access and Privacy Office is, I've just listed the hyperlink there. We all follow a privacy policy that's here at MUN, and for information requests at MUN, all the hyperlinks are there. We don't use them a lot, but sometimes we'll come up with a new idea and we'll say, these data sets haven't been linked before. How do we manage them and how do we get the data? So these will tell us the steps that we have to go to in order to get the data. So one of the big things, the Access to Information and Protection of Privacy Act, it talks about privacy. We're all very aware of our privacy. I don't want people to be able to go in and take my information out of my health chart. So we have to follow privacy. So it's a mandatory reporting of privacy breaches by individuals to the Information Access and Privacy Office, which gets forwarded to the Office of the Information and Privacy Commissioner. It's usually willful. It's like you hear it on the news sometimes that an employee will look up information on patients or that sort of thing. So it's willful. They say, oh, I think so-and-so's in hospital. I'm going to see what they're in for. Or I want to see who their doctor is. So it's you're deciding to do it. You're accessing it willfully, and you know that you shouldn't. You're accessing or attempting to access personal information that's not needed to perform a work task is an offense. So when I worked as a nurse, I had global access because of the type of work that I did, but I was only allowed to access those patients that I saw specifically. Even though I had the access for global and I could check on my mother upstairs or my neighbor down the street, I certainly wasn't allowed to do it. And if I did, or I even attempted to do it, then that is actually a criminal act under the legislation. Best practices for information handling that we use here: we do not transfer any data from anybody to anywhere unless it's an encrypted device. So our USB keys are encrypted, our laptops are encrypted, and if we use remote access when working from home, we only allow VPNs. And the VPN access will only be able to be on a MUN asset, like a MUN computer or an Eastern Health computer. We cannot do it on a private computer. So we're very protective of how we transfer data and store data and keep it. So what are your obligations? Researchers in any capacity, we deal with students, research assistants, nurses, doctors, we have PhD students, we have scientists. We all have a moral, ethical, and legal obligation to honor others' rights to privacy and especially maintain confidentiality of a client's personal information. That's first and foremost in everything that we do. All team members, including patient partners with access to personal health information, are required to complete a free online educational program about the Personal Health Information Act, called FHIA. And in case anybody is interested in it, want to be able to do it, the hyperlink is there. All of our team members, including patient partners with access to personal health information, all sign an oath of confidentiality. They must all conform to MUN policies. And the oath of confidentiality is also recommended for team members, including patient partners, who are not accessing personal health information. And the reason that we get them to do that is that we could be in a meeting and they're included in the meeting. And even though they haven't been responsible for obtaining the data or analyzing the data, they're still privy to what's going on in the room. And they shouldn't take that outside the room and say, oh, I was at a meeting the other day and Dr. So-and-so was ordering too many tests, or I heard this, that the patients, there's too many patients going for CAT scans. So it's really important that it's a part and parcel of our team that they have to sign an oath of confidentiality as well. So how do you get data? I mean, there's so much data out there. How do you get it? This depends mostly on the type of data that you need. Do you want record level data that's housed within a health institution like Eastern Health? Is this information that's already collected by someone else and you want to use it for another purpose? This is a secondary use. So I have collected for 10 years a whole lot of information on colorectal cancer, types of tumor, patients who've had it, what age, what type of tumor, what stage of their cancer. So we collected and basically built a registry. And once we did that, we have so many different researchers now who are wanting to look at different pieces of it. So they will come to us and they will make an application to us to say, we would like to be able to look at how many of these patients died within 3 years or how many of them received chemotherapy. So that's actually secondary use. They're not collecting it. We've already collected it for another study, but we would grant them permission to be able to do other studies on already collected data. You can get data from the regional health authorities. All the regional health authorities collect mounds of data, tons of data. It's health related. You need permission from the data custodian, and that's usually the Director of Decision Support and Planning for the health authority. You cannot apply for any of these until you actually have approval from the Health Research Ethics Board. And HREB is the ethics place that we all go before we start our studies, and we get approval. And then once we have their approval, then we apply for approval for the data from the different authorities. Regional Health Authority individual approval, such as Regional Professional Advisory Committee or RPAC. So you get ethics approval from HREA or HREB. Then you have to apply to the institution. So if you're looking for information from, say, Eastern Health, you would have to apply to their RPAC and see if they would be prepared to give it. And then you also usually have to have a letter from the data custodian, who would be the Director of Decision Support. Supply decision support team with a list of your variables. They will ask you the time, who are a member of the team. So once they see all of this in process, they will then be able to give you permission, or they'll say, no, this is not of value to us, and I've never seen it turned down yet. I've seen it sometimes tweaked, but I've never seen it turned down. So somebody just came in with a question: how does this process differ from quality improvement initiatives within an organization? Quality initiative or quality or program evaluation is not classified as research. That's ongoing evaluation of a process that's within place. That does not require ethics. If you wanted to compare it, if you were going to put an intervention in and you wanted to write it up as a research project afterwards, then you would ask for ethics up front. But as a program evaluation or program planning, you don't need ethics for it. The Newfoundland Labrador Centre for Health Information, which is NELCHI, they like to be called a centre, collects and stores all health-related data for the entire province, including mortality. Health Research Ethics Board approval must be sought before you make an application. You then complete a Newfoundland Labrador Centre for Health Information secondary use application online. You choose your variables from their data dictionary that they have, and then it might be, the thing about the center is that they house their data in silos. So you might have 15 different places that you need to link all of this data. So in order to link it, it may be a long process. So you don't expect to make an application one day and then that you're going to get it within a couple of weeks. It can actually take months. Sometimes you might even have to wait for legislation from the government for approval to be able to do these linkages. So it can be quite a long process. But the center has all of the health information for the province. So anything that you need, you can basically get it from them. This is the process that you get now if you're going to go to the center. You make a request to their committee. They have an internal consultation with their subject matter experts, and they will call you in for a meeting. They coordinate the meeting, then they request, then you submit a final application. Then they'll come back to you and tell you how much this is going to cost. Or if you're actually under a service agreement, then we have a service agreement under what we call the Translational Personalized Medicine Initiative. And anybody who's doing research under our umbrella will not have to pay for it because we have a service agreement that we actually provide the funds to note you when they do it. It goes to their secondary use committee. They review it. The CIO will approve it. The data custodian then approves it for the service NL data. Data extraction and linkages are performed, and then the data file is reviewed and disclosed to the requester. So you can see that of these 11 steps, these can actually take quite some time. So as a researcher, what is your responsibility? It is everybody's responsibility to think about what you share and with whom you're going to share it. What did you state in your ethics application? You might state something in your ethics application, and then as you're doing your analysis, you'll come up with this idea that, wow, I never even thought of this. Oh, I think we're going to now look into this. Well, you know, that's not technically legal. That's sort of data dredging, and you should actually finish that project that you're going to have, or make a second application to ethics as a secondary application, because now all of a sudden you can go off and study something else that you didn't appreciate was there even in the first place. So is the person you're sharing this data with part of your team? Do they need to have all the information or a portion of it? And if you're sharing, can the way that you're sending data identify the person? And if so, should you actually do it? So security is a big thing. We promote security constantly. People are sick of me saying the word security. Data must be kept secure at all times. I don't care if it's anonymized. I don't care if it's de-identified or coded. It has to be kept secure at all times. Researchers must ensure that the safeguarding of data and information against loss, accidental or intentional destruction, and corruption. That's your responsibility. Don't put it on a laptop. Put your laptop on the back seat of your car and then go on in and do your shopping or go to dinner and have someone steal your laptop. That's negligence. That should never happen. Your data should be on a password-protected, encrypted asset, and there should be no way of tracing it back. But you should never put it in a place that it can actually be hacked. Identifiable data is not permitted to be sent via email. Identifiable data should be sent via a VPN, and it should always be encrypted. Confidential information should be destroyed in a secure manner. If it's paper, it should be shredded in locked bins. We're now moving away from collecting information on paper and then entering it into a database. We're trying to skip that process because papers get lost. They get jumbled up with other things. They're not secure. So we're asking people now to build their data sets so that they can enter directly into it. Laptops, Blackberries, iPhones, flash drives must be kept secure. Filing cabinets should be locked. Files must be transported in a secure manner, both internally and externally. Do not leave files unsecured in your vehicle, and always use encrypted drives only. Oh, we got a question? How do you define a VPN? A VPN is actually a process that you have to apply for. It is a direct link, so it's like opening up a conduit from your computer into where the data set is held. So that if you have a laptop that is, say, memorial owned, I have a laptop. If it's a really bad working day and the university is closed, but I need something that's at the office because I'm working from home, I can work through a VPN because it is a high security line, and it's in a conduit. You can only get it if you have, like I said, a memorial asset or an Eastern Health asset. You have to apply for it. It goes through a process committee to see whether or not you actually need it, and if so, then it will happen. It takes a fair bit of time, and not everybody can actually get a VPN. So if you're working at Memorial University and you have some questions about privacy or confidentiality, Rosemary Thorne is our privacy officer. And all employees of Memorial are responsible for the protection of the privacy of students, employees, alumni, donors, research participants, retirees, and others whose personal information is in the custody and or under the control of the university. All employees are expected to undertake privacy awareness training authorized by the university's Information Access and Privacy Protection Office. Every employee that comes under the Translational Personalized Medicine Initiative, they end up having to sit through a PowerPoint presentation that I've developed that's based on all of the privacy officer's information. It also includes FIA. It includes a lot of information that the Ethics Board has, which is on the Tri-Council Policy Statement 2. And then once people have reviewed that, they will sign an oath of confidentiality. If they breach their confidentiality, they are, depending on the level, it will be reported up to the dean, and they can actually lose their positions over it. And they can probably go to court. There's another question. Okay. Do you have any advice regarding surveys for quality improvement and evaluation in personal health information? Again, if you're doing a survey, how much you have to look at what your outcome is. What is your research question and what is it that you're trying to answer? So if you're only looking at ballpark figures, then you don't need to have personal information or personal health information. We looked at how many physicians were ordering one particular blood test. So we knew that there was 60,000, the amount of information that we got back from Eastern Health was there was 60,000 tests in this 1 year. We wanted to see how many patients were actually coming back for serial blood tests because this was a useless blood test. So we got a particular number, but we didn't use that. That wasn't their MCP number. It meant nothing to us. So if you don't need to have personal identifying information, then you don't need it for surveys for quality improvement. But if you do, then there's things that you can put in place like coding and take an MCP number off and give it a separate code and keep a master file separate that would give you a linkage should you have to go back to it. I'm certainly available if you want to come and talk to me or email me further on that. That's a whole ball of wax, to be honest with you, and I'm really happy to help because I can help you get through some of the things and just see what it is that you're looking for so I can help you decide what data you might need to request. I don't know if that helps or not, Nikki. Anybody else have any questions? Will you share contact information with you? Yeah, okay, perfect. Oh, that's you. Yeah, so you'll get all of this, and like I said, Kris said, and I said, we're more than happy to help you with any of this. It's a bit of a landmine if you're just getting started.
Okay, well, this was a very short but interesting, I guess, presentation. Thanks to all guest speakers. You might have a lot of questions. I do realize that there was a lot of information in a short time. So we will share the email addresses and contact details with you. So please feel free to follow up with any of the speakers to, ask them any questions you may have, and they will be happy to meet with you. I would like to announce our next webinar. This will also be our last webinar from our training program, and this will be about knowledge translation. And I'm pleased to announce as well that we will have a special guest speaker all the way from BC, from this BC support unit, Alison Hoons, who is an expert in knowledge brokering. So she will tell you all about the why, what, and how of knowledge brokering and how you could use that to reach the persons who could benefit from your research projects. So please sign up on Eventbrite for this webinar. And if there are no any further questions, I will share the presentation with you and the email addresses of the guest speakers and also a little survey. We would like to get your feedback and learn from your experiences. So please complete the questions and feel free to contact us anytime. Are there any other questions or comments? Kris Aubrey is still here and Elizabeth Dix is still here. So if you have any questions for them, they will be happy to answer them. I see nobody typing at this point. So we will be in the room for a little while, so feel free to share your questions in the chat box. And thank you all for taking the time to attend this webinar, and hope to see you next time, April 13, for our last webinar. Thank you all.